Cuando podáis, le dais la vueltecita a las burbujas, eso es. Ya está, ¿no? Purgado. Okay, so let's start. This man has a relatively large gland with about 100 grams of volume, and he's very bothered with his symptoms and decided to undergo holmium enucleation of the prostate. Here, coming in, that's the middle lobe. Okay, let's go on with the fiber. That's a UO, okay, so not so close to the bladder neck, and we can activate the laser if you want. Pretty far, huh? Brilliant. So we're going to use the Quanta System laser, the 150 watt laser with the virtual basket with settings of 2 and 50. So that's going to be the demarcation of the 12 o'clock limits of the operation. There's some mucosal bleeding, and this is quite usual. So see the sphincter edge, so we could go a little bit further down, I think. Yeah, I want to be relatively close. Relatively close to the edge between the adenoma and the sphincter, huh? Vertical. So this is a virtual basket setting, which is a pulse modulation setting for holmium, and as I will try to show, it provides improved hemostasis and coagulation and cutting, properties. Here's the sphincter edge, so it's possibly okay here. I always like to mark this white line at the beginning of the procedure because it's a safety measure, and I think also it protects the mucosa from breaking, and which can result in the epithelialization of the sphincter. Okay, so here is the verumontanum. Okay, so we cut on top of the veru to connect to the other side here. I'm now trying to generate a posterior line of attack so we can carry out our dissection. And posteriorly, all these small vessels from mucosa will stop bleeding, and I don't think there is any advantage in chasing these vessels because they are sometimes hard to coagulate. They are in the mucosa, and I think it's better possibly to establish a nice line of dissection, line of attack, and then when we generate a slightly bigger space, we can tackle any bleeder that arises with much better chances of being successful. Also, if you think about it, as we detach the adenoma from the capsule, many of these vessels from the mucosa are going to be disconnected. Here, you see, this is what happens if you continue upwards. Many times the mucosa of the sphincter will break, so we want to break it ourselves. So cut it, you see, following this white line, and keep the mucosa on the sphincter. And that's why I like to to touch the apex very carefully. Try to protect. Maybe we could see a little bit better if I could focus the image. Also, it is important to connect. You see, initially I dissect the lower part of the apex, and I connect it with the posterior dissection line we were carrying out. You know, we were dissecting. A little bit more posterior section here. You see, that gives the apex mobility. Again, with these bleeders, I don't bother because they're going to stop as soon as we detach the adenoma from the capsule, and unless it's very, very bothersome and very, bleeding too much or bothering us with the visibility, I don't usually do anything with it. Here, as we are coming up towards 12 o'clock, here it's important to follow the direction of the fibers. You see, if you look at the capsule on the right hand side, you want to go up following this direction. Now that the sphincter is a little bit away from us, that we are just cutting here at the 12 o'clock region, it is important as we try to dissect the anterior apex to take the proper route. So you want to go up, 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 keep going up, you see, towards that direction, and not go towards the midline very soon and leave adenomatous tissue behind. This is the way to protect the sphincter and at the same time ensure that the enucleation of the anterior tissue here is anatomical and complete. Here, you see, we are just okay, so that's the 12 o'clock region. This is the lower aspect, you see, of the sphincter. This is the white line. So now we're going to cut here again, a little bit even on the adenoma to gain better access, and to try to find the proper plane of the adenoma at the apex. That's being extremely careful to dissect the posterior aspect first and connect here, you see. Here you connect with the posterior line of dissection, the line of attack, as I was naming it. This is all posterior, you see, we are just... And by doing that, you see that we gain a lot of space and a lot of access to try and continue with our apical dissection, coming up and following the direction of the fibers of the capsule here. You see they're looking up, going up, up, up. This time we look at the left side of the screen. You see, so when we come here, we see the direction of the fibers at the left of the fiber and come up, 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 all the way, trying to connect with the previous 12 o'clock incision. You see, the apical liberation was quite good and quite fast. So now the operation hopefully will be quite fast as well, because you can take some time to liberate the apex, but when you succeed to liberate the apex early and fast, then the rest of the operation is usually a piece of cake. Just as I said, try to look at the line of attack, the line of dissection, keep it in the middle of the screen, and concentrate on how you're going to aim your laser. You want to aim your laser towards the line of attack at the beginning, but as we progress and the angle of the curve of the capsule starts changing and starts medializing, you have to start firing a little bit closer to the adenoma, a little bit closer to the adenoma. We're coming upwards, trying to follow the direction of the fibers of the capsule. I'm crossing over to the other side, but you can see that most of the anterior aspect of anterolateral aspect of this lobe is being completed. The wonderful aspect of pulse modulation, and in this case a virtual basket, is that we can work concentrating mostly on dissection. You don't have to concentrate on keeping a good hemostasis as you go, because it's going to happen automatically. You see that the double pulse coming out of the fiber opens the plane very nicely, and the second pulse probably is responsible for this excellent first pass coagulation that will help us dissect the plane. You know, probing always, you have to question if you're following the good plane or not. You get a lot of clues from the tissue and the way it looks. You see, but you have to be constantly present, constantly evaluating what you're seeing, you know, letting the energy do its work is the best scenario. When the energy does the dissection, you see it's usually taking the proper plane, but of course you are the conductor of this orchestra, you know, you want to conduct it properly, and you do that by aiming against the line of attack or a little bit more close to the adenoma, depending on what you see, what is the quality of the tissue, what you judge is going on. It's happening here, for example. We are starting to see this change in the fibers. These are fibers going this way, and over here I thought I saw some vertical fibers. We have to watch for that, because that's going to be the place where you're going to enter the bladder. And if you see these fibers, you don't want to go against them, you want to go a little bit below, because you want to look for the bladder neck, and usually you have to descend because of the spheric shape of the adenoma. You want to come down, down, down until you find these vertical fibers that will signal the entry into the bladder. Of course, we want to keep more or less a symmetrical dissection here. You see, these are vertical fibers, these are circular fibers. That's the entry into the bladder neck. But let me finish this side a little bit better, because we worked a little bit more on the other side than here. So come up, let the energy investigate for you. Let the energy help you find the good plane, the plane you want to follow. If you see, for example, up here, as we go up, it starts looking a little bit more flimsy, then you have to get closer to the adenoma, you see. Correct a little bit your plane of dissection, because you don't want to go deep in the capsule. You want to adapt to the curve. Here we are. I'm doing a little bit of contact of the fiber with the tissue to try to make it even better in terms of cutting. Here you see that's not too bad. These are just fibers that I want to cut, so we have a nice access to the plane and we can go around. There we are. You see, sometimes it's not really contact laser, it's just getting the fiber very close, so it's the explosive effect of the first bubble opens up and cuts, you know, sometimes fibrous attachment. Some planes open very well when you fire from the distance without any need for contact, but sometimes when the tissue is very stuck, when the plane is very hard to separate, then you might be able to do a little bit of closer firing, not really touching, just, how would I say, just, you know, caressing the the tissue with the fiber, so you're very close, but you're not touching, and of course you're not putting the fiber against the tissue very hard, because that will make a little hole. And with this pulse modulation setting, sometimes the hole can go 2 or 3 millimeters in depth, which is sometimes the dimension of the capsule in certain areas, you know, of the surgical capsule. So you want to keep the fiber away from the tissue, or in what I would call near contact sometimes. When it's more difficult to dissect the plane, then near contact, almost contact, is also a possibility. I hope, of course, I am trying to progress fast. I'm very confident with the planes, I'm very confident with the anatomy. So maybe initially when you're starting your experience, it's better to keep the fiber away and maybe do the same thing, even if you have to do 2 or 3 passes, you know what I mean? So initially take it very easy with the fiber, keep it slightly separated, and then you have to judge. You know, we're judging a lot of things. We're judging the plane. Is it a good plane or not? Is it the right depth or not? Are we leaving tissue? Is this a nodule that I have to take out? Maybe. So we have to probe it. You see, we have to investigate. Then, if we see that we're going too deep, then we have to correct again. You know, this is the idea. Of course, you don't want to go deep to a point where you do a massive perforation, but certainly you want to check, you know, if the quality of the work you're doing is good or not. Okay, so this is the entry into the bladder. Let's enter. I'm going to confidently cut it here, you see, and I will circumnavigate the bladder neck, circumcise, cut it following the direction of the fibers. When people say that they preserve the bladder neck, I don't really understand the concept, because there's no clear anatomical landmark to show where the bladder neck ends and where it starts, you know. So I just try to follow this. To me, it's a very abstract concept. I don't understand what is preserving the bladder neck. What does it mean in endoscopic surgery? And I think all these concepts that are a little bit difficult to understand, are not adding simplicity, you know, to the discussion. I'd rather, you know, just follow the anatomical clues to be able to take the adenoma out. And of course, we're going to cut on the bladder neck. We are going to leave it quite open. The adenoma has to go through it as well. So here we are. Coming. You see here, when the plane is changing direction, I keep the fiber very close to the adenomatous edge, you see? This way I can adapt to the curve. Here, you see, trying to come close to the adenoma and trying to see where it wants to go. So using the energy to our benefit and to our advantage. There we are. So it's important to move around the area where you are dissecting, because sometimes you feel a little bit stuck. You don't know why you're not being able to progress properly, but then if you go around and look at the same area from the other side, then you see things more clearly sometimes. So keep moving. Don't get obsessed with continuing the dissection only. You know, just sometimes you have to come out a little bit with your scope and get some perspective to understand where you are, especially when you are not sure. You know, we also get some tactile feedback. Many times I know where I am because I can see my scope, I can see where it is pointing. So very easily I know if I am pointing posterior or anterior, and very easily I know where I am. Of course, that's why when people watch videos from HoLEP, they have sometimes difficulty understanding. No, the surgeon usually has the benefit of knowing where he has his hands. You know, so he has a big advantage when he wants to interpret what he's looking at. He's not only interpreting the endoscopic image, he's also interpreting a lot of sensory inputs, especially tactile inputs that are telling you where you are, if the tissue is hard or not. You know, if you can move the prostate a little bit around easily or difficult. So you get a lot of information that you have to process to carry on with your operation safely. Okay, so now you can see we have nice fossa, there's no bleeding now. Let's see if I can, this was the middle, if I can lift this lobe, you see I lift it until I can then push it, all right? So now this lobe has gone inside this is the prostatic urethra. The lobe has tilted inside, you see, and then if you go to the other side, you can try to do additional movement. And then this is usually going to show you very well all this region. You see here, this is the bladder neck area. The adenoma has tilted. It's almost going in the bladder, so there are some attachments at 6 o'clock. So we have to cut them, recognize the anatomy, and the enucleation is going to be finished pretty soon. Here, bladder neck, you see we can follow. Here, and as I said, I can't tell how do you preserve the bladder neck. It's not possible. Maybe they are meaning I don't do a very deep cut, or I don't do additional cuts to the bladder neck, but you see, preserving the bladder neck is a shady concept, very strange, difficult to understand under my point of view. Okay, so here, this is mucosa now. This is why it bleeds sometimes, because and I can push the adenoma totally into the bladder. And of course, when you finish the enucleation, the adenoma is no longer inside the fossa, and the flow of water is more chaotic. It's not so, you know, typically when we irrigate all these regions, no se mueva por favor, we irrigate them with the adenoma inside, so there's a small space and the water flow is going to be very good, very fast, and it provides very good visibility. But you see, when we look here, we see some bleeding. Of course, if there's any active bleeder, we want to chase it, we want to find it, we want to make it stop if we can. Also, it's nice to review the 12 o'clock region in search for these cling-ons. You know, these little pieces of tissue clinging. This is the trimming phase, which has shortened a lot with the pulse modulation lasers. You see the quality of hemostasis is really good. I have to say, I don't like to see a crystal clear fossa, because that's sometimes a sign that you have coagulated too much. You can see how thin the capsule is in some areas here. We're nearly retrotrigonal, but if we look at the sphincter, we have done a very good job preserving the sphincter. And also, you see the mucosa. I tried to break here, but we stopped it in time. So, excellent continence from day one, I think. Now, let's get to see the mucosa here. You see here, you can get sometimes some small bleeders, but they can make your life miserable when you do the modulation. it's better to try to control them. Well, not too bad, not too bad. Okay, vamos a morcelar. So, let's change the instrument. Tira fuerte, con decisión. Ahí, muy bien. Good. I'm now changing the laser cystoscope for the morcellator. Okay. With the help of my nurse, who needs to understand the procedure very well and help you to do a very fast and efficient change. Tenemos aguas abiertas, ¿verdad? Sí. Always ask for the water, you know. Get good habits that allow you to control a little bit, because you have to be looking at the screen all the time. And you don't want to, I mean, you can't look at the bags. You know, you cannot take out your attention from the screen. So that's why you want to have a good team, a team that understands all the steps in the procedure and that can help you very fast and very swiftly if there's a need for it. Our morcellation is happening very nicely. It's taking place very nicely. You see, it's a soft adenomatous tissue, so it tends to go very fast and very nicely. So sometimes we can take out 10 or more grams per minute, which means that if this adenoma is 60, 70, 80 grams, it will take us 6, 7, 8 minutes, which is a big change in nucleation, because it becomes much faster, much simpler, and very competitive procedure. This man will have his catheter removed tomorrow morning, so in less than possibly 14, 15 hours. And if he voids normally, he can go home. So the classical option was to do an open prostatectomy or a very, long-lasting or difficult TURP for a man with such a large gland. So there we are, nice morcellation. I'm realizing it's important to clean your glasses as well, because my glasses are so dirty that I can't see very well. I'm thinking there's something wrong with the visibility, but it's my glasses, so I have to clean them again. Okay. It's coming. Oh, there's only a little bit of both lobes. It's interesting that sometimes we start with one piece, but the morcellator divides this piece into further pieces. So sometimes some nodules are detached, sometimes you just cut the adenoma in two without noticing. So don't believe, I mean, if you finish with the piece you're doing, don't assume that it's the only piece there is, because there might be other pieces, and it's not, impossible to leave a piece behind. When you leave a piece behind, the patient complains of voiding normally and then suddenly stopping very violently. The flow stops very violently, and then he has some pain, and then you have to suspect that you left a piece of tissue inside the bladder or the fossa. We usually look, but sometimes, even when you look, it can hide and you might miss it. If it's a small piece, sometimes it comes out and the patient is scared, thinking that he's losing tissue through the urethra, or it can be uncomfortable, painful to extract it, So you have to be careful and assume that there will be more than one piece, even when you have done en bloc enucleation. So then the round nodules at the end, and I think we have finished. Let's check inside the fossa. There's a little bit of oozing, and again we can see the sphincter. Perfect. Vámonos.